Hi everyone, this is your podcast for eating disorders. Healthy people need to regularly consume a rich variety of foods that are sufficient for energy needs, cellular growth and repair, and maintenance of sufficient weight. Depending on your age, sex, physical condition, activity level, height, and other variables, you should eat somewhere between 1,500 to 2,500 calories each day, staggered over 3 meals and a few snacks to accomplish these things on the screen. Eating is a normal response to hunger and should cease when the person attains satisfaction or that comfortable, full feeling. They believe that anorexia and bulimia affect 1 to 4% of the general U.S. population. They have a hard time determining the incidence of bulimia because most clients with this disorder binge and purge in secret, and their weights may be normal or relatively normal. Historically, anorexia and bulimia have been diagnosed most frequently in white, affluent, well-educated adolescent and young adult females. Both disorders, however, are becoming more widely distributed among social classes and cultures. We're seeing some increases in the male population, and they believe that for these reasons that are on the screen: popular emphasis on fitness, lean muscularity, stringent weight requirements for certain sports, thinking about wrestling, for instance, and that they have to maintain or be down to a certain weight to be able to wrestle in a class. Higher incidence in the male homosexual population is seen than in the male heterosexual population. Causes of eating disorders vary and are influenced by impaired psychosocial functions, medical complications, and psychiatric comorbidities. Eating disorders have a multifactorial etiology, developing from a complex interaction of individual, family, and socio-cultural elements. You can see on the screen that some of these factors are thought to be a vulnerable personality: dieting that becomes uncontrolled, genetics, onset of puberty, major life changes or stressors, family functioning style, and socio-cultural emphasis on slimness. There are some theories that attempt to explain, sorry if that got fuzzy a little bit, theories that attempt to explain eating disorders. From a biological perspective, which I didn't change the slide, research findings strongly suggest that eating disorders may originate, at least in part, from hypothalamic, hormonal, neurotransmitter, or biochemical disturbances. There is also evidence supporting a genetic element to eating disorders, and that's been considered for over 100 years. Studies from the NIMH, or the National Institute of Mental Health, suggest that anorexia, bulimia, and obsessive-compulsive disorder are associated with excessive levels of vasopressin, a brain hormone. When you look at psychosocial theories, people with eating disorders initially may diet, they lose weight, it leads to an enhanced physical appearance, and then they get approval for their weight loss. They may continue such dieting even after they have reached a normal or below normal weight. As weight loss continues to a dangerous level, approval from others turns to concern. Regardless of the nature of interest from others, however, clients continue to receive attention centered on their weight. Thus, such attention may reinforce these maladaptive eating behaviors. Disordered patterns become automatic, and they're fueled by an ongoing drive for thinness and a neurobiological fear conditioning of weight gain. When you look at sociocultural theories, some social scientists argue that socialization of groups at high risk for eating disorders leads members to evaluate themselves against certain idealized standards of appearance, laying the groundwork for a negative body image. Clients who cannot naturally meet the ideal and begin to diet or exercise compulsively may progress toward an eating disorder. There's even family-based theorists. Family advocates suggest that certain overprotective patterns rather than helping to cause eating disorders, may be displays of normative behavior when children have a chronic and potentially life-threatening illness. Several studies suggest that some cases of eating disorders are associated with childhood physical or emotional abuse and childhood adversity. So, looking at the question, which of the following theories suggests that eating disorders may originate, at least in part, from hypothalamic, hormonal, neurotransmitter, or biochemical disturbance? And if you chose A, you chose wisely. Here's just a view of anorexia nervosa, and we'll talk about that one in a minute. So the eating disorders we're going to talk about today: anorexia nervosa, bulimia nervosa, which includes binge eating and purging, and also binge eating disorder. Characteristics of anorexia nervosa. The signs and symptoms here include a voluntary refusal to eat, typically a weight less than 85% of what is considered normal for height and age. These clients have a distorted body image and view their bodies as fat. They're obsessed about food, and they're excessive in pursuit of vigorous physical activity to try to keep the weight off. The typical client with anorexia nervosa, white, affluent, well-educated adolescent, young adult female, often described as compliant, obedient children, having perfectionist tendencies, and tend to be high academic and athletic achievers. Characteristics of bulimia include episodic, uncontrolled, rapid ingestion of large quantities of food, occurring alone or in conjunction with the food restriction of anorexia. They compensate for excessive food intake by self-induced vomiting, obsessive exercise, use of laxatives and diuretics, or all of these behaviors. The typical client with bulimia is a young, college-educated woman who achieves highly at work or school and tends to be passive, dependent, and unassertive. Her family may be disorganized, non-cohesive, in conflict, and characterized by confusing sex role expectations for women. Alcohol and substance abuse problems are common, perhaps indicating increased impulsivity in this group. When you look at binge eating disorder, this includes recurrent eating binges, guilt, shame, and disquiet about binging, and marked psychological distress. Typical client with BED is male or female. It's pretty even split. Medically overweight or obese. You do not have this slide, so if you want to pause a minute and write these things down, that would be good. There are some physiologic consequences of starvation. And the first is amenorrhea, and that is the absence of abnormal cessation of menstruation. Lanugo hair, which is that downy kind of fine hair that you see on a preemie, for instance. They have this fine downy coating of hair, so you can also see this in a person that's been starving themselves. Hypotension, bradycardia, hypothermia, constipation, polyuria, and electrolyte imbalances. We're going to look at some labs in just a minute, but I just want to give you one thing. Low calcium levels may cause leg cramps in these folks. Numerous studies show an association between depression, anxiety, and eating disorders, but determining whether mood disorders lead to eating disorders or vice versa is difficult. You can see on the slide that between 25 and 50% of clients with anorexia have a lifetime history of anxiety disorders. Up to 33% of clients with binge purge behavior have a comorbid alcohol or substance abuse problem. Bulimia frequently coexists with major depression, they feel, and that happens in 36 to 70% of patients. Substance abuse, 18 to 32%. And personality disorders. So here's a question. Anorexia and bulimia nervosa co-occur in 30 to 64% of clients. What do you think about that? That's actually true. People with eating disorders rarely seek help. They are typically not motivated to change and often leave treatment. Many of them never seek or receive any intervention, and some recover spontaneously, whereas others have long-term problems. One study found that after 21 years, 50% of clients with anorexia nervosa had recovered. 25% had intermediate outcomes. 10% still met the criteria for anorexia, and 15% had died due to complications of anorexia nervosa. I had a patient once. She was 43 years old. She weighed 69 pounds. She was 5'3". They admitted her to orthopedics where I was working because we had the only private room in the place. We could not have any running water to her room. We had to put a bedside commode in there. We had to immediately empty the bedside commode if she urinated. If she got flowers, we couldn't allow them in her room because she would take the flowers out and drink the fluid. What she was looking to do is just fill up her stomach with just all fluids and not eat. And that way she felt, satiated and didn't feel the need to eat food. I wasn't there. We were waiting on a bed for her for a treatment facility, and she never made it to the treatment facility. One night when I was not working, she actually cardiac arrested, and they were unable to code her and bring her back. Well, they coded her, but they couldn't bring her back. So it was a memorable situation. So here's another question. And I think I already alluded to this, but bulimia nervosa has higher rates of recovery than does anorexia nervosa. And that one's true. In a 10-year study, approximately 30% continued to engage in binge eating or purging behaviors. The 20-year study found that adult roles in marriage and parenting were associated with significant decreases in bulimia in women, but not in men. Due to the complex nature of eating disorders, multidisciplinary or multimodal care is indicated, and it includes individual and group psychotherapy, behavioral therapy, CBT, dialectical pharmacologic behavior therapy, nutritional therapy, family therapy, and psychopharmacology. Pharmacology or pharmacologic therapy usually is not the primary intervention for anorexia, but antidepressants or anti-anxiety drugs might benefit clients with depressive, anxious, or OCD symptoms. Typical treatment settings are community-based settings with an interdisciplinary team and can include schools, community mental health centers, clinics, private offices, day treatment centers. Sometimes inpatient treatment is required. And as you can imagine, clients with anorexia are more often hospitalized than those with bulimia. And this is due to that low weight, depressed mood. They also have low potassium levels, lack of response to outpatient therapy, and the families get discouraged and demoralized. Other factors that lead to inpatient treatment include that client's desire for treatment and diagnosis of maladaptive personality problems such as impulse disorder or borderline personality disorder, make that person more likely to be treated in an inpatient setting. One of the therapies that works well, particularly in children and adolescents with early onset anorexia, is behavior family systems therapy. And this approach blends behavior mod, cognitive therapy, and family therapy. So it comes in 4 phases. The assessment phase, the interdisciplinary team comes together to coordinate care with the client and family. They engage the family in therapy and check the client's weight weekly. They conduct history, behavioral, social, and functional analyses. Second phase is control rationale. The therapist encourages the parents to take charge of the client's eating and deals with their reactions. The therapist also coaches the parents to develop an appropriate behavioral weight program. The third phase is weight gain. The therapist begins to refine the weight gain program and introduces non-food related issues. He or she begins CBT, such as cognitive restructuring. Family psychotherapy and psychoeducation also take place. During weight maintenance, control over food gradually returns to the client. Team members teach healthy ways of maintaining weight. Family interactions increasingly become the focus of therapy. Behavioral family systems therapy works well, like I said, in younger patients. In adults with anorexia of long duration, this approach has not been effective. So, looking at assessment, the first thing we have to do for physical assessment is get an accurate initial weight. And then I'm going to talk about some other assessment findings in just a little bit, but I wanted to talk a little bit about labs here. Some abnormalities associated with anorexia include nutrition-related anemia, leukopenia, thrombocytopenia, and decreased chloride, calcium, magnesium, and phosphate levels. Elevated BUN levels may be related to dehydration or muscle wasting. Severe malnutrition may lead to elevated serum levels of hepatic enzymes and cholesterol. They can also have a sick thyroid syndrome with reduced concentration of T3. Decreased levels of FSH, which is the follicle stimulating hormone. The luteinizing hormone, or LH, estrogen and progesterone are associated with a secondary amenorrhea. Bone density measurements are often low. And in long-term starvation, the body depends on gluconeogenesis, or the body's dependence on gluconeogenesis is decreased, whereas the use of ketone bodies as a cellular energy source is increased. In long-term starvation, you'll see depressed insulin levels and increased glucagon, cortisone, epinephrine, and growth hormones, which promote that fat breakdown in adipose tissue, and that therefore the fatty acids are used to supply energy to cardiac and skeletal muscle cells, and ketone bodies to sustain brain tissue. When that person has depleted their adipose tissue, the breakdown of muscle and visceral protein is the last process to supply energy for life. Lab studies in bulimia generally show fewer abnormalities, but repeated regurgitation may produce volume depletion, hypokalemia, and metabolic alkalosis with decreased chloride and increased sodium bicarb. Laxative abuse may lead to hyponatremia, hypokalemia, and calcium and magnesium depletion. Diuretic abuse may lead again to hypochloremia, hyponatremia, and hypokalemia. Hypokalemia is particularly worrisome because it increases the risk for life-threatening cardiac dysrhythmias. I don't know where this slide went, but we're missing a slide, and it is actually the components of the health history. So I'm going to leave this slide up while I talk a little bit about this. Components of the health history include nutrition, elimination, reproduction and hormones, activity and rest, and psychosocial. The assessment for these folks is complex, and you need to take into account all of these components of the health history. You also need to look for behaviors with eating disorders that involve manipulation or deprivation of food and fluids, which can result in those severely disturbed metabolic processes. So again, we'll look at those in just a minute. There is an assessment tool in your book that talks about, or that really gives you an inventory for clients with eating problems. It's Assessment Tool 26.1. Very, very helpful, so you can see some of the questions that are asked when you do an assessment on one of these patients. Symptoms related to disturbances in nutrition and metabolism, dehydration, hypokalemia, cardiac dysrhythmia, hypotension, bradycardia, dry skin, brittle hair and nails, lanugo, frequent infections, dental caries, inflammation of the throat and esophagus, swollen parotid glands from purging, amenorrhea, hypothermia, a lowered pulse rate as a response to excessive exercise and starvation. Here's some findings on physical exam of clients with eating disorders. When we look at nursing intervention and we look at classifications of nursing interventions, we're going to look at behavior management. We're going to look at eating disorders management, nutrition therapy, self-awareness enhancement, and weight gain assistance. Due to the multi-system nature of eating disorders, data analysis may suggest multiple nursing diagnoses, and clients who are medically unstable should have nursing diagnoses specific to their medical problems. Most nursing diagnoses for clients with eating disorders center on psychosocial problems. We need to plan collaborating with the client and usually family to formulate an appropriate treatment approach and to set goals. Some of our short-term goals will include decreasing anxiety, stopping the weight loss, restoring the person to an acceptable weight, and normalizing eating behaviors. The types of interventions that nurses use, again, are under these classifications. Some teaching points for clients with eating disorders. We want to offer the following suggestions to clients with an eating disorder and their family members. Provide unconditional love. Don't base that love based on what their body looks like. Focus on the person rather than on the eating disorder. Give the client the power to make decisions and facilitate changes in matters other than eating. Demonstrate united support for one another and plan for the client's treatment. And prepare for hospitalization if the client becomes medically unstable, or for rehospitalization if he or she experiences a relapse. Some desired physical outcomes and psychosocial outcomes. Desired physical outcomes include weight gain, normal laboratory values and vital signs, and return of secondary sexual characteristics and menstruation. Desired psychosocial outcomes include a realistic perception of body image, direct expression of feelings, improved self-image, a sense of control over self and environment, and constructive family processes. And I'm sorry that was all on this next slide. So again, it's really important to attempt to attain these goals to help this person as a nurse recover from an eating disorder. And that's the end of that podcast.